I am Bill Pearson, Director of Boston Healthcare Fellowship. Welcome to our videocast. Today we're talking with Michael Dykstra, who lives in the Longwood Christian community and will graduate from Harvard Medical School in just a few weeks. After a preliminary year here in Boston, he will head to Michigan for radiation oncology training. He is pursuing a career in global health as a cancer physician. In this conversation, Michael shares some interesting perspectives about COVID-19 from working in resource-limited settings. After about the 5-minute mark, the conversation turns towards lessons for our own healthcare system and thinking about engaging human suffering as healthcare providers. Recently, you've been involved in a project in writing up some educational materials for COVID-19 response and resource-limited settings. Can you tell us what that's about?
The module that I helped with, we titled it Global Innovation and Collaboration. And while we are sort of new to these ideas that we are a resource constrained setting, there are places where living with resource constraints at baseline is much more common. And so the thought of this project is, what can we learn from places that are already dealing with some of these issues on a more regular basis than we are? Because the people who are near the problem are the ones who are best equipped to solve it.
What do you think the impact will be of COVID-19 in these resource constrained or limited settings?
There are some communities where it's very hard to enact these social distancing measures. We live in nice places, we have our own bedrooms, we can easily keep 6 feet between us and those around us. But in many parts of the world, if there are 10 people living in a room or house, that would make it a lot harder to actually follow these measures. Currently, they've done a pretty good job of sort of isolating in most of these settings. Across the continent of Africa, across Latin America, really the doubling time has never reached what it did in a lot of our high income settings, Italy, Spain, US. I think the long term is sort of something a lot of us are concerned about, because we can't do total lockdowns forever, especially when a lot of people may be having to make decisions between whether they can go out and work and get food and have money for food, or whether they will be able to not get COVID-19. Without a vaccine, this could stay around for a long time, and a vaccine won't happen for a long time. So I think there's concern about what will happen there.
What can we learn from resource-constrained settings about how to engage this pandemic?
I think one of the best and most exciting examples has been community health workers. In Rwanda, for example, they have probably the most robust community health worker program in the world. There are people in essentially every community that are selected by community members as someone who is well respected, and who then works directly with government health officials to disseminate information, as well as to do very practical check-ins. And in addition to sort of strengthening the health system, it's also providing essential jobs to people in a time when we have a tremendous amount of unemployment. We're investing in our health system, making it stronger, and also alleviating some of these economic effects that we have. So I think that they're a great model to be used more broadly going forward. One way that they will use it in the COVID-19 times is that they will help with contact tracing, which is when you have a positive case, it's important that you test and quarantine anyone else who has been in touch with that person when they were probably infectious. I think that we will reach a point where contact tracing and rigorous testing will be the way to decrease COVID-19 without as strict of social measures as we have right now. And so, for example, Partners in Health has actually been tasked by Governor Baker in Massachusetts to implement a community health worker contact tracing program here. And that's really based on their work in Haiti, in Rwanda, and elsewhere. Having people in the community who are able to converse and connect with people and really figure out who all needs to be tested will be critical. And I don't think that it would have the sort of breaches of privacy that are being proposed by some of the more technical innovations.
Or the negative responses in India, where healthcare workers were going into slums and then they were being attacked by the mob. And I guess the difference there is you have a healthcare worker or somebody from the government coming from the outside into the community. Sounds like in the Rwanda model, you actually have trusted members of the community that are giving that kind of leadership and intervention.
Unfortunately, some countries have had some security challenges around COVID-19, and like in the Ebola crisis in 2018, this is one of the case studies we included in our module. There was a public health decision made to not allow some provinces where Ebola was raging to do elections, which from a public health standpoint could have been the right decision, but unfortunately it was the first democratic election in the history of the Democratic Republic of the Congo, even since its independence. Then what happened is there were rebellions in those provinces, and then there were actually attacks directly on health workers and health facilities because they were thought to be part of a conspiracy to rob them of their voice, which is understandable given the history. And so we need to make sure that as we implement these things, that we're not doing so in opposition to culture and to the thought of the community.
When we think about improving our healthcare system, we think about policies, better science, better technology, and we don't really think about the human capital. And I wonder if that says something about our belief system about health.
Yeah, absolutely. The COVID-19 pandemic is really testing a lot of the relational aspect of every aspect of life, because we're not able to meet with people outside our house in person. Really, family members aren't able to go to the hospital and see their loved ones, regardless of how severe their condition is. Even patient-provider relationships are often happening like this interview that we're doing instead of in person, because this will help decrease exposures between people who may be positive.
Even though you're just on the other side of that wall right over there.
Exactly. I'm hoping that this kind of experience will make us hunger more deeply for authentic relationship. And so I think that trying to adapt our health system to that paradigm, I think will be important.
I wonder post COVID-19 what the conversations are going to be about healthcare. Watching the news, the heroes in the healthcare system aren't the healthcare system right now. It's the respiratory therapists, the critical care people that are helping people through this and giving people courage and hope and celebrating these victories. And yet it seems like much of the healthcare debate hasn't really factored in the importance of the human being when it comes in delivering care. Task shifting is an example in the module of how you took the people resource and you were meeting human needs through people.
Yeah, it's a technique that's been used internationally a fair amount. So, for example, in COVID, someone who has gone through medicine or anesthesia now is critical care trained, usually is running all the ventilators in the hospital. But now some general medicine people, some general surgery people are also coming in and helping manage ventilators, because that's what we need.
That would suggest that the problem isn't the number of trained individuals as much as redefining regulatory issues, for instance.
Yeah.
We don't often think about our regulatory issues as a constraint in our world-class healthcare system.
Yeah, absolutely. I think we're sort of seeing the end result of having a system that is designed more around sort of a capitalistic model of how do we have like a market of healthcare. And so on the day-to-day, it overall works, right? Because roughly how many masks you'll need, and so your supply chains can supply that many masks. You know how many ventilators you might need at the peak of flu season, and so that's covered. And then all of a sudden, when our needs go up tenfold or 100-fold for some of those things, we are in an uncomfortable position. We need to shut down the entirety of the rest of the healthcare system to make space for patients in a pandemic.
The gods of capitalism and control aren't working for us in that situation. But the good news is that there are other resources. There are other ways to address problems rather than being constrained by those ways of thinking.
Yeah.
I think that's what interests me from a theological perspective, is that our capacity as humans is often constrained by the thing that we worship.
Mm-hmm.
This is what Jesus meant when he said, you have eyes but cannot see and ears but cannot hear. because idols have eyes but can't see and ears but can't hear. If your reality is defined by a certain social force, then that limits what you're able to see, what you're able to hear, what you're able to do.
I think we all, at least I can speak for myself, but in having all this time to reflect and think more about, about suffering, about health systems, about how we're able to respond to this. I've been thinking about some of these themes after my friend in my medical school class passed. So I had been thinking about it for months in advance of COVID too. But I think Christianity is a religion that has a compelling explanation for an all-powerful God who comes alongside suffering, right? And I think sometimes the question of why suffering is harder, but I attended a conference in college, the Urbana InterVarsity Conference, and they had a session about suffering. It was two people who had done work in Haiti for a long time at an orphanage. They talked about the experience of the earthquake. Essentially, the orphanage that they had worked on collapsed. Then they were asked, like, how do you deal with this degree of suffering? Because we've all had suffering in our lives, but I think having an orphanage full of children who you love collapse is about the worst I can imagine. And their response to that question was, well, we don't have a God that prevents suffering necessarily, but we do have a God who comes alongside in suffering. And that's where we see our role too, is coming alongside suffering. And so that for me really was a sort of profound moment of shifting my perspective on some of these issues of suffering. And I think I'm going into cancer medicine, right? So I'm planning on being around people who suffer for the rest of my career. That's sort of one of the central tenets to me of what that means. It's just to be with. It's not necessarily always about the new therapy, the new technology, the things that, like you said, our health system really values and we often think are the things that can save us, are these technological innovations. But I think coming alongside suffering is a deeply powerful experience for anyone, and often is what we're looking for more than a cure or a new technical innovation.
Any other last thoughts or whatever? This has been really great conversation.
Yeah, absolutely. Thanks for hosting it. Lived in most of last year in Botswana. Some of my friends are still there. Shout out to them. My friend Mahmoud decided to stay, and my friend John Tarpley and his wife Maggie are staying as well. So wishing them the best as they're still trying to help improve this crisis there.
That's the surgeon from Vanderbilt, John Tarpley.
Yeah.
One and only. That's
one and only. Yeah. No, he was an incredible mentor during my time there. So shout out to him for being an inspiration to us all.